I hope it's on. Good morning. Could you take your seats, please? My name's Rod Harris, and with Steve Bell on my left, your right, we co-chair this event, the Allied Professionals Forum. It's presented by the International Alliance of ALS-MND Associations and the Motor Neurone Disease Association, who are the sponsors and producers of the symposium that's on over the next few days. I'd like to acknowledge the traditional owners of the land on which we meet today, the Gadigal people of the Eora Nation and their elders past and present. I'd also like to acknowledge up front the very strong and ongoing support that we've had from the ALS Hope organisation from Philadelphia. Their support for this event has recognised that there is a gap between stepping up from doing good work to presenting at an international symposium that will be on over the next few days, particularly for allied health professionals. And this event has been very successful in being able to showcase speakers, give them the opportunity to present and to take that step up. And I'm really pleased that a couple of our graduates, as I'd like to call them, are speaking on the main platform at the symposium over the next few days. Just some minor housekeeping. Lunch will be served outside. The toilets are down, left as you go out the door and left again. If there's a fire, I usually just say run, but there will be direction given by hotel staff. So if you hear a siren that might be akin to something that should be a warning, await instruction and follow the directions of those who are the fire wardens or empowered to give directions. Personally, I'll be running. On Thursday in the morning, there is a sex and sexuality conference. It's limited to 50 people. There are 35 registrations so far. And if anybody is interested in attending that, they need to book with Diana at the registration desk. And I'd like to put an apology. There are a couple of changes, or there's two changes to the program. One, I managed to send out the wrong abstract for one of our speakers, and Melanie, I apologise for that. And we have Samar Aoun coming in for one of our speakers who unfortunately is not able to be with us today. Well, welcome. This is a great day. It's a great opportunity to hear what's happening around the world in support of people living with ALS-MND. And it's also a great opportunity for you to meet each other, to share contact details and to join the pieces together so that it truly is a global fight against ALS-MND. You're all here because you want to be, and that's really important. We're all here and want to hear things without interruption, so if I can ask you to turn off your mobile phones, pagers, beepers and anything else that makes a noise. I'm dreadful, so if a phone goes off, don't be surprised if I confront you. It's important that we show respect to the speakers, but it's also important that we show respect to the other members of the audience who are trying to concentrate. If you're so important that you can't turn your phone off, then you're probably too important to be in here today. So we're going to kick off, and Steve and I are going to alternate chairing. I'm going to chair the first session, Steve will take over for the second, and away we'll go. So to start with, I'd like to introduce Sally Bowl as our first speaker, and she's talking about "You're living until the day you die, there's nothing like home." Sally.
I'm going to present a contextual framework that I'm going to hand over to the experts about themselves, life, and living at home. Every individual has a right to have a voice and to be heard and to live with meaning and purpose. Every day we work with people with motor neurone disease and we witness the courage and determination for them to reach the goals, and they don't know it, but a lot of the time that's our aspiration, to keep going. In Victoria, we know the majority of people will want to remain living at home for the duration of their illness, and many do remain at home. Yet at times, health professionals, because of the high complex care of motor neurone disease, can feel a sense of overwhelmingness and helplessness, not dissimilar to the person with motor neurone at times. The safest option, therefore, sometimes from a health professional's point of view, can be alternative care. But is it? Hang on. MND Victoria supported 403 people with MND across Victoria. Sadly, 120 people died in Victoria last year. 30% stayed at home for the duration of their illness, and 70% were at home up until a month before they died. It takes a team of carers to support someone to live at home, and forward planning. We work with specialist and community services to form care teams across Victoria. Our regional advisor service alone linked with more than 450 service providers across Victoria to create care teams in local areas. Our equipment library worked with 150 allied health professionals and sent out 1,000 items of equipment. One of the services that helps and supports people to stay at home is the palliative care service, which we work closely with. It can include specialist palliative care teams from inpatients and community, Royal District Nursing Service and GP services. And sometimes there's a combination of those services involved to support a person. Okay. The different services will sometimes provide a different service themselves, and also will work with people at different stages through the disease. You'll hear people talking about Mercy Care. They're referring to Mercy Western Palliative Care, which is one of the palliative care services that covers the metropolitan region in Melbourne. You'll hear Banksia Care, that's another palliative care service that covers some of the northern region, and you'll hear the district nurses, and there are a lot of the nurses working out in the rural areas and also in the metro areas in Melbourne. Anyway, that's enough of me. I'd like to hand over to the experts. It's a simple video. It's in people's lounge rooms hearing their views, because sometimes it just does get down to the simple things of being with people, hearing what they're saying. Hopefully. Oh, there we go.
My name is Duncan Bailey. I am 33 years old and I was diagnosed with sporadic motor neuron disease 4 years ago during a working holiday to Amsterdam. I enjoy playing board games and computer games, following current events and spending time with friends. I share my rented house with my wife, Catherine, my sister, Fiona, and my friend, Grant. I am originally from New Zealand and my sister is my only immediate family here. I love being around my family. I've only been married for a year and a half and I haven't lived in the same country as my sister for over a decade. I enjoy the bustle of people's ordinary lives. It is a vicarious thrill when you cannot participate. As I wrote this in my room, Grant was watching a movie in the lounge and it's nice just to be around and involved. I don't want to be the center of attention. I just want to be around. I also like being around people whose values I share. I'm worried about making friends in residential care. Even carers and case managers are a funny bunch. I am about to move into an apartment on the site of an old prison and so many people have asked me if I'm worried about ghosts. I trained as a mathematician. We don't believe in that nonsense.
It's always wonderful just having him around, and to come home to him not being here would be too strange. You know, as much as being here is good for him, it's, you know, part of our lives and part of our family as well. So, there have been some people who have been, I think, afraid of touching him in case they think he'll break. I mean, he won't. He really won't. But you do really need to, I think, have confidence in yourself and have knowledge of, how to help people with Duncan's condition, because I think one of the challenging factors is that motor neurone disease affects different people in so many different ways. So the same approach doesn't work each time. It does need to be a relationship. It does need to be one where the carer talks to the family, talks to their client, Duncan in this case, and understands what, in his particular instance, that they need to be able to do to support him. And I think that there is an element of, as Duncan says, the communication between allied health carers and between the medical profession, where we are getting that very specialised and, as I say, high quality care. I think the connection between the two could be improved, and if that can be done, I think it would just make a world of difference to the care that's provided in the home and to the carers themselves in their knowledge and how they provide care to individuals with very specialised conditions.
Yeah, my name's Darren Van Shake. I've only just turned 46. We built the house where we are 16 years ago, together. Her way. The way things are, I am at the moment, I'm happy just taking it a day at a time and enjoying it, and being here. This disease is only one way. There's no point where you stop and you come back. And you've just got to relate to that and think, oh, today I can't do this. Tomorrow I'll have to find out how I'm going to do something differently. I'm going to try and live as normal a life as I can for the duration. Just having people around me who I know, I can rely on, I feel they've had a special place in my life for many years, and I don't want to be far away from them at this time. Megan said something to me a couple of weeks ago. I've got 2 older sons, and we spent a lot of time together driving in the trucks and that, and Megan's not going to get the chance to do that. And she said to me, I guess this is the time that you and I are going to spend together as father and daughter, because you're not going to get another chance, are you? I said, yeah. I said, that's why I want you with me.
That's his wish, to be at home as long as possible, and we want him at home as long as possible.
And suddenly there's old people around me going, we can do this for you and we can do that for you. I think, no, I'm all right then, for the moment.
Yeah, we had
And I haven't worried since.
We had a cry and then we moved on.
Yeah. There's a lot of problems with trying to get some palliative, some respite care, and the only people who really came to the fore were Bethlehem, and they put their hand up and said, yeah, we'll take him.
It was through Royal Melbourne, the doctor.
And that
at
was
Royal
through the
Melbourne.
registrar at Royal Melbourne, yeah. And he sorted it out there, and then on the day, the following week, I had 2 weeks in that respite. Yeah, well, I have Mercy Health. They've become a regular visitor once a fortnight. And we also have a counsellor which comes through Mercy Health, morning care and the afternoon care. That's changed taken a lot of pressure off everyone.
My name is ERGUNHUSEYIN. I am 53 years young. Been diagnosed with MND for 15 years. I love outdoors and hate staying in bed. I did love gardening. The back strip is my new garden, which is nearly finished. To see, we get constant visitors, which I love to listen and chat on my eye gaze machine. I have always been living home. in hospital only when I got sick. I don't think I can handle not seeing my family's faces. For 6 years I was silent. 7th year I got my eye gaze and never shut up since. I need to talk. First words were, I love you all. My life had changed for better. I can talk and defend myself if I need to. I even wrote a book using my eyes. Only negative thing about this machine is it's not portable to carry on my chair. For this reason I hate to go to hospital and respite because I can't communicate. I usually take my letterboard with me, but they are afraid to use it, and it takes time. Anyway, I get undivided attention at home from my family. That's why I don't want to leave home.
We stay a family. If he's home, we stay together, and he's part of the family as well. You know? We are happier if he's home.
And he doesn't miss out on the normal stuff.
Yeah.
You know, he's still a part of everything. And he's writing something there that he'd like to share.
We watch Home and Away together.
Yeah.
Have family
We
time.
feel like we're a normal family, you know, when he's home.
Sometimes we feel like we're a bit luckier than most because there are a lot of dads out there that are working around the clock and don't, you know, actually get to be home for their kids, whereas Dad always is, and he's always sitting here. We always have to have, you know, deep chats about absolutely everything.
Yeah, we get help through DHS. Without their help, we couldn't manage, you know. I get carers home and help me with him, daily tasks. And without them, I don't think, you know, it was possible. And Austin Hospital looked after his ventilators services, and they do come and change his tracheostomy every second month.
Hi, my name is Pam Wilson. I'm 46 years old. I have 2 girls. Stacy is 21 and Haley is 15. I like to read, go to the movies, and staying home with Steve and the girls. And as you can see, I love kookaburras.
Pam's still the runner of the family. Pat, doesn't matter what she's got, Pam still runs this house. Pam's still in charge.
Try.
She still checks all the mail, still tells us what bills to pay, when to pay them, because she's in charge, you know? So, yeah. That's why she stays at home with us.
All the changes with M&D happen so quick. No notice ahead of changes. My family all know my needs just by eyes and head movements.
Well, the close friends we've got, they make regular visits. It's not visiting hours at hospital. It's Saturday, Sunday, it doesn't matter. It's the girls from work, after Pam's old work, after school, they come and visit. They don't have to battle the traffic and run home, get tea, go to hospital to visit Pam. It's an open house here, and Pam likes it like that. All the stuff that Motor Neuron Victoria gave us, you know, beds and things like that to deal with. We couldn't have Pam home without all that stuff. Banksia Palliative Care being here with us, which is a tremendous thing. Claudette from Banksia, Pam's regular nurse. She comes in once a week, once a fortnight, or when needed. And just knowing 24/7 I can dial that number, and within 5 minutes they're on the phone back to me, asking me what the problem is. We're offered some good services off Banksia Palliative Care. One that we use and still use to today, and that's Pam has a massage once every fortnight.
Love my massages and Jill from Banksia.
And not only with the massages with Banksia, they offered us support in the way of for the kids, if needed.
They are all there for me. and I love my husband for caring.
We came from the city and I was a nurse and I had a lot of children, had 6 children, been home a year now, and I was in the nursing home for a year. But it was like I didn't want to sit there and wait for things to get worse. I wanted to use what time I had. Everything here has a meaning to me as a person. Like every book in the bookcase, the pictures have meanings and they have stories.
We've been together 50 years, so, you know, it's, we're surrounded by our past. I mean, I just wanted Jan back because we'd always been together.
I thought this, no matter how good it is, it's run very well and very ethically, and but it is, after all, a sort of factory for looking after disabled people, and so you have to say, well, I've got 16 to do this morning, or 20 before I can go and have a cup of tea, and that's okay. I mean, that's understandable. But it was the lumping people in together, and the task. It's a task rather than a human being. It's a bit dehumanising.
Jan can say to me, I need another drink of water. Fine. I'm here, here's a drink of water. If she's in hospital, she might get a drink every 3 or 4 hours, if that. So funnily enough, in a way, the treatment in a hospital is no longer adequate.
But I have to say, it wouldn't have happened without the district nurses.
Oh, they've been terrific.
Mean, they were wonderful, and I had no idea what a fantastic service it was, you know. They just stepped in. I think it was so many people, like maybe 6 or 7 people coming from slightly different places to contribute to really just looking after me at home, physically, financially, all of those things, and that seemed amazing, because I would sit here thinking, still in the wheelchair, thinking, how did I get from there to here, where people are in a very logical sort of way working out a way that I can live at home.
Just, I guess, the take-home message, the challenge is how we can support each individual to live at home, if that is their wish and their family's wish, in comfort, with confidence, with meaning and hope. Thank you.
Do we have any questions? Oh, you're not going to be one of those audiences and just sits on your hands. Any questions at all? Well, please join with me in thanking Sally, and particularly those that were in the video. I'd now like to introduce our next speaker, Dr. David Oliver, who's talking about the effects of withdrawal of non-invasive ventilation on the professionals involved. David.
Thank you, Rod, and thank you for the organisers for asking me to come. What I'd like to do is talk about some of the issues I think that we face with coping with people with non-invasive ventilation. All over the world, there is increasing use of NIV to cope with respiratory failure. And withdrawal is talked about on occasions, with patients perhaps, with families, and within professional teams. And in the UK, we have the National Institute for Health and Clinical Excellence, who produced guidelines last year on NIV and MND. I was on the working party, and as a result of the guidelines, we very clearly said that we should be talking about withdrawal and end-of-life issues when we start testing for respiratory function, so that it's upfront and saying to people, this is what we're talking about. Certainly when NIV is started, and there is a leaflet for people with MND, which actually has the statement that you can ask what to do if you decide you don't want to continue with NIV. So that document has been a challenge to us to be looking more often at our role in discussion of NIV. However, we know that it is stressful. The withdrawal can be stressful for patients and families, and often for professional teams. For the medical staff, who may be most involved in the decision-making, but other team members and other staff. Within units, it may be non-clinical staff or volunteers who need help and discussion to cope with all the issues involved. So we thought, a group of us, and I'd like to acknowledge Cassie and Christina, who are very much involved in this study. We asked members of the Association of Palliative Medicine in the UK, that's 1,000 doctors, from consultants, training grade, local GPs, people in medicine who are involved in palliative care. And we did an online survey of members. All the members were contacted and told of the survey, and there were 11 questions, really looking at their experience, at their grading, their involvement in MND-ALS, and their involvement on withdrawal. And we had scales of the challenge of withdrawal, personally, emotionally, and ethically. We gave them an opportunity to talk about what problems they may have encountered, and a section for free comments. 134 people responded, which was many more than we thought for an online survey of such a big group. And I think it showed the issue is a real issue for many doctors. 64% of those people who replied were consultants, 82% were working in hospice units, and the 97% were involved in the care of people with MND. And only 60% had actually been involved in withdrawal of NIV, but there were still people interested, and 40% had been involved with more than 2 occasions. So these were people who had variable experience of withdrawal of NIV. And when we asked them about their challenges and the problems this caused them, when we asked about what were the practical issues, the average on a 10-point scale, 0 being no challenge and 10 being extremely challenging, was 5.8, and 7% said it was very challenging, and nearly 50% scored 7 or more, so at quite high levels. On the emotional, that was even higher, 12.2% saying very challenging, and ethically it was just a little lower at 5, just over 5 for the average, but again 7% saying it was challenging, and a smaller number scoring 7 or more. So it seemed that there were real practical issues. There were certainly emotional issues. And I know doctors are not supposed to have any emotional problems or any issues. UK doctors have a high suicide rate, a high divorce rate, and one of the highest alcohol rates. But we cope with stresses without any problem. What were the free comments they made? A lot about the conflicts within teams when NIV withdrawal was discussed. Very much that it's a planning of a large team to ensure that everyone is clear about the ethical issues and the rationale. their doctors talked of the drain on themselves of not only supporting patients and family, but supporting all the other members of the team. That the understanding of those ethical issues varied across the team, and that one or two people put nurses need emotional and ethical support. This was not helped that the NMC, the Nursing Council, actually until about 2 years ago, said that any nurse involved in withdrawal of NIV could be liable for prosecution for assisting suicide. They only changed their view the day before a national meeting to discuss a case of someone who had NIV withdrawn. So there are real issues that people have memories and have heard from their top nursing council that NIV withdrawal could be seen very deleteriously. There was a feeling that advanced care plans were helpful, but it's still very early in the UK on advanced care planning. And people weren't quite sure, did this really, should we take care of it? Should we listen to it? Should we not? Had things changed? What was going on? There was a feeling of a lack of guidance, the very practical issues of what to do. Can I use sedation? Should I use sedation? Will I be accused of terminally sedating someone and assisting suicide if I use sedation? The lack of support from other teams. Were respiratory physicians teams or MND teams thinking in the same way and saying the same things or different things to patients and family? And that the guidance was there, but it was difficult to find and difficult to share amongst the whole team. Communication obviously was a big issue. There was a feeling that although the NICE guidelines talk about withdrawal of NIV being discussed when NIV started, that a large number of people had never, ever had any discussion about what happens after the treatment had started. And they were facing their own deterioration, their own, in other spheres, their mobility, their speech, their swallowing, as well as having to cope with NIV. And there were some very unrealistic expectations of some patients and families. This had been, the NIV had been started perhaps in an emergency situation, and there hadn't been discussion. They didn't understand that it wasn't going to, they felt they were going to become better. The MND was going to get better as a result of this treatment. And there had been some discussion, and the need for discussions, as I said, with patients, if possible, with families and with staff. And then the ethical issues. This feels like euthanasia or assisted suicide, one or two doctors wrote. And I could sympathise with this because I've been involved with now 2 people with invasive ventilation where we've stopped the ventilator. And I pushed the button, and I've been on the ethics committee and know all the ethics. You know, I knew ethically, in this bit of me, I was doing a completely ethical decision. The patient was involved, I had clear consent, they didn't want this treatment. But this bit down here said, David, you pressed a button and the person died a few minutes afterwards. And the head and the heart talked to each other, and quite often the heart was starting to win. There were real evidence of team conflicts. People not sure whether to stop this NIV, great discussions, great arguments, and the need to explain the ethics again and again because of the understanding of those ethical issues. Another comment, in theory, ethically, legally and practically it should be straightforward. In reality, it's not. I'm causing the death was something that came over again and again. So these are experienced doctors in palliative medicine who are dealing with dying patients day in, day out, but were finding this a real challenge. The other comment was that this is an emotionally charged situation. The patient and family have so many emotions it affects the whole team. And we've got our own reactions as well to face and to add into that. So there was a real feeling that all these emotions made it so emotionally charged that it was difficult to make the decisions to actually come to a decision and to do what was necessary. That advanced care planning wasn't always in place. And I hold my hand up in the UK, we are starting with advanced care planning, and it's at a very early stage. We do have patients who have made advanced decisions to refuse treatment, which are legally binding, is specific and in writing and for withdrawal of treatment. But the number of patients are small. And the other thing, and I know I'll get criticised as being a doctor, but the doctor was feeling isolated. One person wrote, walking onto the ward at the allocated time and being treated like an executioner is not easy. And legally, under the UK systems and the Mental Capacity Act, it is the doctor who has to make the final best interest decision, using the information from patient, family and the rest of the team. But the doctor is responsible in the end for making that decision and making those and actually being involved. And there was a lot of people were saying about the stresses of that. So where are we? What's this shown? We're hoping to continue this, looking at it in more depth. But I think we can show that the withdrawal of NIV is stressful for all concerned. There are real emotional stresses for teams. And I think this is only one tip of an iceberg within palliative care. We think there aren't the stresses. This has shown particularly some of the stresses that there are that we never acknowledge. That they're there, but everyone just carries on. It's always said that at UK hospices, everyone is terribly nice. We're always nice to each other and to our patients. And there is a tendency not to discuss properly, not to face these difficult issues and say this is really difficult and horrible because we're too nice. There's need for real clear communication within teams. And again, I'll come back to there were the nurses and the OTs and the physios, but it was the cleaners, the secretaries, the volunteers, the people who we didn't think about normally, that needed that support, seeing a patient looking quite all right one day on their machine and being dead the next day when the doctor had done something in between. Very hard for volunteers. That we need to have guidance and clear guidelines to normalise the process. That support is necessary within the team during that process to support us all. So what are the recommendations? I think we need to ensure patients and families understand about NIV and the possibility of withdrawal when it's instigated. That advanced care planning should happen at that time. We can't wait. It needs to happen when it started. And that guidance and guidelines are going to be helpful. That discussions within teams caring for people with MND-ALS need to acknowledge withdrawal. They need to acknowledge the ethical issues, discuss them, look at the practicalities, have a clear view. And finally, just to acknowledge, Cassie Rowe-Haynes is a registrar in palliative medicine who was very much involved in setting this survey up. Thanks to the APM for facilitating the questionnaire and all the members who answered so honestly. And we now have an MND special interest group as a result of this survey, so we hope we can move on and have further discussion. Thank you.
As usual, David challenges us to not just think of the person with MND, but those others who are involved in care and support. And the International Alliance has a policy on patients' rights, and in sitting there I was thinking, yeah, but we actually haven't talked about the rights of doctors to be adequately supported and the cleaning staff. I think we have to look more broadly with some of our policy issues. Any questions, please?
Very nice presentation, David. I have a question. I'm Pamela Cazzoli from Ohio. When the patients that withdrew, decided not to go on, was there any report about their status? Were they dependent on NIV at that point?
This would usually be people who are 24-hour dependent, and so actually stopping the NIV would lead to their death in a very short period of time. Not necessarily, and that was one of the stresses. Someone had said, you know, we thought we would stop at 9 o'clock, and at 10:30 they were still alive, and the family were saying, but you told us they'd die in a few minutes. What's happening? And that was very, very stressful for professionals and for the whole team.
Another question? Yep, down the front. Sorry, down the front first, and then up the back.
Hi David, Bernie Corr from Beaumont Hospital in Dublin. We tend not to have many people requesting to have their NIV withdrawn, and when they get to the stage that they become dependent on it 24/7, it's kept in place and they die. So we haven't had those issues. Those issues tend to apply to patients who are invasively ventilated as opposed to our NIV patients.
Obviously, it's for invasive ventilation, it's a real issue. But I think what we've seen is there are patients who are dependent, who are deteriorating. And I mean, one doctor talked that he felt that there was a body being kept alive with the NIV, and that they could see that they were living another week longer than they would have done otherwise, and that had been distressing for the person and also all the family and the carers. So I think there are occasions. As you say, I've had patients I was going one in the evening, everything seemed to be all right. I said, I'll see you tomorrow morning and we'll think again. And he died overnight. And I took a deep breath and sighed and was relieved. But looking back, we should have been having those discussions weeks before and days before about what we were going to do.
Up the back.
David, thank you very much. Pete Allcroft from South Australia. A couple of comments. One, I think if I'm correct, you said you'd only done this a few times, and I think that would be my experience in the last 10 years. So it's not something we do very often, so we do feel anxious about it because we're not very practiced at it. How do you make sure that patients aren't depressed and depression is driving this request, particularly in an anarthric patient? I know that's a big question.
Can I leave now?
Come on, David.
I think it is very difficult. I mean, I think it is trying to assess. I mean, hopefully we will have known these patients for longer than the last few days. So we would have had a feel of what's happening before, and had a chance to discuss the issues of depression, the other issues that they may be facing more with them beforehand, and think of treating that. But I think it is a real issue. But I think when it becomes someone who is really 24-hour dependent, you know, other factors may be less important than the fact that they feel they are deteriorating or they've made an advance directive if they can't communicate and they are still on the machine, that they want that stopped, and we need to be listening to those decisions as well. But it isn't a really difficult thing but it would be from our appreciation and also involving the family in how they feel things are. But it's, if anyone's got a good way of working out if someone's depressed who can't speak and is restricted with a mask, can you see me after?
The last question down the front here.
Martine Verwij, Switzerland. What about the situation at home?
This would happen at home with support of a palliative care team or the district nursing team, and could happen at home without any problems. The only issue at home is if it has been decided that it will be withdrawn at 9 o'clock and the nurses are fine for until 5 o'clock and the person's then alive at 5:15, and it gets a bit shaky, but there's no reason why this shouldn't happen at home or in the unit. We've been involved in both.
Thank you very much, David. Just in the interests of me escaping if there's a fire, could anyone standing at the back please find a seat? Our third speaker today is Catherine Knights. She's going to talk about the South East Motor Neurone Disease Network, an evolving model to support professionals and improve quality of care. Catherine.
Good morning. We all know, those of us sitting in this room, that MND is an extremely challenging condition, and professionals want to do their very best for people. However, for the majority of professionals working with people with MND, especially in community settings, this is a very small part of their caseload. And yet they are the professionals that have to deal with the day-to-day problems. They are not experts and can feel very isolated. So what I want to tell you about today is what we think has been an exciting initiative which helps to support these professionals. For those of you who are not familiar with the UK, the areas that I'm talking about during this presentation are in the extreme southeast of the country, so the very bottom left-hand corner of the map. The South East Regional MND Forum was set up in 1999, and it covered the counties of Kent, East Sussex, the London boroughs of Bexley and Bromley, and covered a population of about 2.7 million. This stemmed from a multi-agency meeting of professionals with an interest in MND from across the region. Its objective was to try and raise the standards of care and equity across the southeast of England for people with MND and their carers through collaborative working. It was led by a working party which was initially chaired by Dr. Gaynor Lloyd, who was a rehab specialist in East Kent. And it was made up of representatives from the multidisciplinary teams from across the area, and it met 4 or 5 times a year. The main activity of the working party was to put on an annual conference, and the aim of the conference was to try and improve local care. It wasn't to replicate the education that was already done extremely well by both the MND Association and other organisations. It was based around workshops to enable teams to learn from each other and to enable regional networking. During this time, we had a couple of special conferences, one on supporting choice at the end of life in 2006, at the time the Assisted Dying Bill was going through Parliament, which wasn't passed, by the way. And then Policy into Practice Stakeholder Days on the National Service Framework for Long-Term Conditions, when that was launched in 2006. We also did some mapping of local teams, mapping of equipment services, and mapping of respite provision, and this helped to highlight the gaps and the inequities across the area. So why did we feel we needed to change? For frontline staff, there were increasing pressures on health and social care professionals. They were facing increasing caseloads, restricted or no study leave, and limited or no funding for education or training. So it wasn't easy for them to go off and attend conferences. There have been huge amounts of uncertainty, and I think especially in primary care. That's my background, and I've certainly been in the position of having been reorganised about 5 times in the space of 10 years, and that's been doing the same job. But it creates huge uncertainty, lots of anxiety, and cuts to services and budgets. And that leaves people feeling isolated and unsupported. At a strategic level, we had reorganisation of the strategic health authorities, and a new strategic health authority was formed a couple of years ago called the South East Coast Strategic Health Authority. They were the commissioning level within the NHS, although now that role has changed, and they now have more of a monitoring function, as the commissioning is in the process of being transferred to be undertaken at GP level. But as part of those changes, West Sussex and Surrey became part of the Strategic Health Authority, and the boroughs of Bexley and Bromley within the MND Association became part of their South London area. So what did we do? In 2009, we had a stakeholder event to work with our colleagues to identify what the challenges actually were and to try and come up with solutions that would work for people. We had a planning meeting in early 2010, and from out of that we developed what we hoped would be a flexible model. So we came up with a steering group to oversee the work of the network, but then we had the idea that we would develop local working groups to look at specific projects. We try and do as much as we could electronically to allow people as little or as much input as they can manage. The membership, as before, of the steering group was from the local regional care development advisors and health and social care professionals from across the region. Although we are administratively supported by the MNDA and the local regional care development advisors do a lot of the work between meetings, we've always felt that it's really important that the network remains separate from the MND Association, hence our own logo, which you can see in the top of the right-hand corner of the slides. Because we feel it only works if the network, is felt as if it's owned by the local health and social care professionals. So we relaunched as the South East M&D Network, which again is open to all professionals with an interest in M&D across Kent, Surrey and Sussex, which is covering a larger population of people now of 4.3 million. And I know this won't mean a huge amount, but this just gives you a rough idea of the map of the new area that we're covering. So what have we achieved since we've relaunched? We now have an electronic membership database, which is currently 272. The membership encompasses the whole range of professionals, so palliative care consultants, clinical nurse specialists, the whole range of therapists, social services care managers, social workers, researchers, regional care development advisors and M&D association visitors. So we're hopefully that we're touching all the people that have got an interest in M&D across the region. The steering group meets for 3 to 4 times a year for about 2 hours. As I've already said, a lot of the development work between the meetings has been done by the regional care development advisors, but that fits in well with their own work plans. We've run half-day education sessions on compassion fatigue in both 2010 and 11, which were held in 3 locations across the region and were attended by more than 100 people. The speaker and room hire costs were covered by the local MNDA branches, and delegates paid a minimal cost towards the cost of refreshments. We've also held 2 respiratory education events, where the team from the Lane Fox unit at St Thomas's Hospital in London came down to demonstrate non-invasive ventilation and cough assist machines. We also carried out some respiratory service mapping, which has helped to inform M&D service development in Sussex. We were absolutely delighted in the course of this year when Professor Nigel Lee, who I think will be known to many of you, agreed to be our patron. So far it has felt too challenging to try and set up the local working groups, but we have been able to do everything that we've needed to do electronically so far. We've continued to hold an annual conference. The most recent one was in September of this year, attended by more than 60 people, and it was entitled Myths and Legends. The keynote talk was given by Professor Lee, and topics included phenotypes and prognosis, is communication only about technology, what are the myths around physiotherapy, supporting carers, and in the afternoon we held an advanced care planning workshop. And on the slide I've just shown you some of the comments that we've had. And 100% of the people who attended that event would recommend it to their colleagues. So how has this improved care? After the mapping of the multidisciplinary team and respiratory mapping, 3 of the teams in the area have reviewed their pathways. The network education events have built relationships in different areas so that it's actually prompted the development of an MDT in an area which didn't have one before. 2 teams have set up peer mentoring schemes as a result of the compassion fatigue sessions. And we've got evidence of direct improvement of individual care. And we're talking about at very basic levels here, where an OT speaks to another professional involved with a person with MND, and as a result of that recognises there's a piece of equipment that might enable that patient to function better, and they have now gone on and got that piece of equipment for them. And it's at that kind of level that we can make a real difference to the care of people with MND. So what do we want to do next? As I've already touched on, there are lots of changes in the way services for people with MND are being developed and commissioned in the UK, and the network wants to try and engage with this. We have recognised that the next step in development of the network is to provide a forum for professionals to exchange ideas, experiences, raise issues, and get in touch with each other between events. So we're in the process of setting up a website which will include an online forum. Our intention is that this will only be able to be accessed using a password, so it will be only open to members of the network. At the moment, we don't feel we'll be able to actually moderate it, but we'll put a disclaimer on that obviously people, the advice that people exchange, everybody is responsible for what they put on there. So hopefully in these few minutes, I have demonstrated a way that setting up a network can successfully engage and support health and social care professionals in the current very challenging climate. So the take-home message is that if you're feeling isolated or unsupported, you're unlikely to be the only person who feels that way. So get together and develop a network. Thank you.
Questions? You've all got perfect networks? Everyone knows how to stitch them up? You must be sitting on your hands. Catherine, what do you think is the key issue in sustaining the network? It always seems to me that there's an excitement and a passion at the start. There's a period of growth, and then things start to fall apart. And how do you keep it going?
I think it's having a core group of people. So I think our people that are on the steering group have a real commitment to keeping it going. If our steering group's meetings didn't continue to happen, then we wouldn't continue to function. So it is very much driven by finding people who've got a real passion for improving the care of people with MND. But also, I think people are very reluctant to get involved because they think, it's just going to take far too much of my time. I haven't got the spare time in my day-to-day role in order to be able to do something like this. But as hopefully I've shown today that, we're talking even for members of the steering group. The commitment in terms of meetings is probably 10 hours a year. The electronic developments have made such a difference. I mean, I was involved back in the days before we had email, and I was, stuffing letters into envelopes and newsletters and things. And it is so much easier. It's so much less time consuming. So use the technology in order to keep in contact with people.
And because no one else has put... Oh, there's a hand at the back.
Pete Allcroft, South Australia. I'm interested why you didn't include at least a member from the MMD associations as a representative, and that's not a Dorothy Dixer from Rod Harris.
No, I mean, our regional care development advisors are employed by the MND Association, so we are working very, they are part of the network. But as I say, we just felt it was important that it was seen to be owned by the local professionals, of which the regional care development advisors are part of the local teams. But we just didn't want it to be seen as something that was all being organised from national office.
Catherine, can I ask another question? What's the kickback then for people with MND? What do you see the outcomes for them out of your partnership?
I think it's giving people more confidence, as I touched on at the beginning. A lot of people working in the community in particular don't have a huge amount of experience of people working with people with MND. And I think that causes them a lot of anxiety, and that can in itself be transmitted on to the people with MND. And just so that the professionals know that they're doing the right thing, or they know that it's challenging, and it's not just challenging for them, it's actually challenging for everybody else, I think then gives the people with MND the confidence that actually the people that are looking after them do know what they're doing.
And there was a question down here.
Robin Ray, North Queensland. I just wanted to know how you actually inaugurated your steering committee, please.
Well, I will confess the steering group kind of evolved out of the previous working party. So a lot of the people who were involved, as it says in my statement, I've been involved with this for certainly more than 10 years. So I was on the original working party, and I'm now on the steering group. But we have engaged people from the other areas. Did I answer your question?
Wait for the mic.
Yeah, sorry.
When you say people from other areas...
So when we increased the area of the network to include Surrey and Sussex, we have got members now on the steering group who come from those areas, because we feel it's important that each area feels that they're represented on the steering group.
And are they across the multidisciplines, or
Yes.
are they...
Yes, so we've got a range of physios, OTs and other professionals involved.
Well, thank you very much, Catherine. I'd now like to introduce our next speaker, Melanie Holmes, who's going to address us on a model of peer supervision group implemented between allied health staff in an acute hospital setting. Melanie. And apologies again.
If anybody does want to ask me about the thing that's in the programme, the bridge of nose ulcers, then do, because I like talking about that as well. So, yes. So, I work as an occupational therapist with VRSS, the Victorian Respiratory Support Service, in a large hospital in Melbourne. The team that we have is fairly small. So, can I just ask, have a think about your settings and your workplaces. So are there issues in your workplace that you'd like to change or develop or get to grips with? Are there things about the timings that people are in and the cover that you have of different staff, which makes it very difficult for you to kind of get people together to talk, to sort things out? If you've got a varied health professional group as well, do you feel that they could work together more closely, that they might, if they work together, they could get a bit of respect, get a bit of the love going? Are there gaps in your practice which you sort of feel are restricted by the times that you work and things like that, and people have things to do, so they work in other places on other days and they have childcare issues and things like that? If it is a yes to any of those questions, then think about peer group supervision. You feel you'll need it. This is us before we had peer group supervision. These are my colleagues. There are 4 of us, 2 social workers, 2 OTs. So, you know, there were issues, frankly, dress being one of them. This is us after peer group supervision. We all went happy and blonde. So, putting it into context. The Victorian Respiratory Support Service is a statewide service, as it says there. We have about 700, a total of about 700 or 800 clients under our umbrella. And they all have non-invasive ventilation or invasive ventilation. So that's quite a big lot of people. They don't all have motor neuron disease, obviously, because that would be a bit skewed. But they are large and take up quite an amount of our time, which is fair enough. So the setting is in a large teaching hospital in the eastern suburbs of Melbourne, and we have access to 8 beds, so 4 respiratory beds or 4 VRSS beds and 4 weaning unit beds, and that's on the respiratory ward. Our team consists of the lovely outreach nurses, and there's one of them here today as well, who actually go out and service the ventilators and see the patients and check that the mask is the right one and do all the pressures and all that kind of stuff, which is slightly beyond me as an OT. Also, we have social workers and OTs, 2 of each of those, and also 2 physiotherapists. Now, the physiotherapists work very much on the ward and implementing patients and working very, very closely with the medical team, because we have doctors as well. The demands and limitations are that we're coming from different, having such small groups of people, we have different expectations because of our professional backgrounds. But we did feel that the social workers and the OTs had a sort of community of practice. We work in quite, because there are only 4 of us and the rest of the OTs don't understand what we do and the rest of the social workers don't understand what we do, then we are very much sort of together. So we thought, how do we make the most of this knowledge and practice? And how do we help with the sort of longevity of what we do so that we stick with the team? So, as we know, supervision is well supported by our professional bodies. It's looked on as a good thing, helps with all that burnout stuff, and to just improve our practice and keep us good at what we're doing, keep our eye on the ball. It obviously has a role to provide different things, so there are sort of administrative and managerial aspects to it, educational aspects to it, and also supportive aspects to it. And the elements of supervision which we look for include looking at for a contract so that we know when it's going to happen and what it's going to look like. Also to ensure that it is supportive and that we have a record of our discussions so that we can go back and check that the things that we wanted to happen are happening. So an agenda is very useful. There can be some pitfalls to it. It can become a bit of a gossip fest. It can be dominated by 1 or 2 people. And there can be a neglect of the educational and supportive aspects because the managerial stuff sort of takes over. So of the 3 types, there's a one-to-one supervision. And obviously that's usually a hierarchical thing. So you have supervisor and supervisee. And that very often has a large management element. There's also the triadic or consultative method, which is where a group of peers get together and then somebody's kind of helicoptered in to do the supervision. And then the one we liked, because we couldn't think of who we wanted to be helicoptered in, the peer supervision. We also have great faith in ourselves, which is a bit sad. The peer supervision model we found after having had a little look around, we considered the 6 thinking hats and all that stuff as well. But the one that we liked, because it's simple, straightforward, gutsy sort of thing, is a model by a German gentleman called Kim Oliver Tietz, and we liked the fact that there was a nice structure to the group. The cost was minimal because we just kind of sat together and talked for about an hour and went through the structure. So there was nobody else that you had to bring in. It improved the collaborative working, and it was all about collaborative working. And it helps because we have occupational therapists and social workers sitting in the peer supervision group. it helped to bring that new light on your methods of working, because you have to explain it to somebody who doesn't speak the same jargon as you do. Gives an opportunity for reflective practice, which makes us all better practitioners. It's also quite mutually supportive and sympathetic, and we hope that it improves, we feel that it has improved the quality and consistency of the work that we do. And you're also, within the method, you're able to look at things in a very systematic, or you're able to look at lots of different things. So you're able to look at sort of systemic issues. So should we have a protocol on this? Do we need a policy about this? Do we need to talk about this so that this happens? It looks very well at interdisciplinary issues. It allows debriefing opportunities as well for any incidents. And it also allows a bit of appreciation and support, and we could all do with more of that. There are roles within the group, but these are transportable roles as well. So a moderator who helps to clarify the issues, who helps to direct the discussions and assist the case presenter with presenting a case clearly and working out what the issue actually is. The case presenter obviously presents some issue which has come up, and it needn't be a dramatic bad issue, it could be a good issue as well. So you can cover nice things as well. And then the consultants who actually think about or provide the feedback on what's going on. And then one of the consultants can also be a scribe as well. And as I say, that rotates around the meeting. So, 6-step process. This is the bit that we really like because it's nice and simple. So first of all, you decide who's doing what, who needs to be cast to do the necessary things. So the moderator, the case presenter, and the consultants. Next, obviously, the case presentation. This should take about 5 or 6 minutes just to run through the bones of what's been going on. The moderator actively listens and encourages the case presenter to get to the nitty-gritty of the problems that they're having. Then the consultants are listening attentively mind, during this phase, and can come up at the end with 2 or 3 questions which just clarify the issues. No judgment or whatever is given over at this stage, so it's just to clarify what's going on. And then the key question is arrived at. The key question really is for the case presenter to understand what it is they're trying to ask about. Is it a sort of an emotional issue? Is it a management issue? Is it a systems issue? After that, there are different methods which the issue can be looked at. It's like looking, through different lenses to look at an issue. And because obviously an emotional issue would need a different set of lenses to a very systemic and organisational issue. And there are a number of different consulting models suggested on Mr. Tietz's lovely website. One of them I particularly like is the headstand brainstorm, which is where you just come up with ideas, but they have to be addressing the issue, but the opposite to the issue that's really being addressed. So if the issue is, how do I contact my community colleagues more effectively, then the headstand issue would be, how do I contact my community colleagues less effectively? And you shoot all your sort of questions at that, or your thoughts about it to that. And then when you've finished the method, the consulting bit, you turn those back on their heads and say, right, how can I do it better? Because I know how to do it worse. That will give me indications of how I can do it better. Then there's the sort of the main consultation. So the case presenter agrees to the suggestions and sort of just has a contemplate about which ones they feel address the issue that they have. And the goal of the consultation really is to get as many ideas as generated as possible. And then the case presenter actually works out which one it is, which one they like. Then the case presenter delivers the statement about what ideas they found useful. There's a very good feedback on it as well. You get almost immediate feedback, which is very good. So you can actually address things directly. The case presenter is then requested to thank the consultants and the moderator for their time and and their ideas, which is very gracious. And then the moderator gives a little bit of feedback about how they've perceived their moderating style and whether they feel that, how they feel it's gone as a project. And then you kind of metaphorically all change chairs and move on to the next problem. So that usually takes sort of half an hour altogether. So you can get through some pretty meaty problems in a reasonable amount of time because you've got a nice structure to do it. Some of the examples of things that we have actually discussed are the withdrawal of ventilation. It's going to go up a lot. And really our from our point of view, being the OTs and the social workers, it's what happens before the doctor walks into the room. But it looks like the doctors need a bit of support as well, so does everybody else. Just set up a peer supervision groups. It's fabulous. Because very often when the family has got to that decision, the morning that it's going to happen, or just before it's going to happen, before the doctor walks into the room, there are things that they would probably like to have happened. Possibly seen a priest or a spiritual advisor, or to have seen all the members of the family. And when those things are done, they would like to see the doctor quite soon after that, because the sitting around bit is just not good. So it's looking at those sorts of issues, whether that's happening in the community or whether that's happening in the hospital. Other and possibly more mundane things that we've done is to work out that actually lots of the information that OTs and social workers gather initially in that initial interview are actually the same. We do have clients who come in for day implementation, so they come in for a day admission. They see the respiratory physios, which is a bit hectic and a bit strange because people are giving them boxes that go puff and things that go on their faces, and it's just terrible, and they haven't slept well. That's why they're there. And so they then get the social worker, the OT, anybody else coming in and asking them all the same questions again. So if we go in together, they only have to say those things once, and then we each go off on our little path of carers and equipment, which is usually, but the information that we hear from each other's assessment is also very useful as well. And we can also do a quick chat, as I was saying, with different people being in at different times and doing different things. It's useful if one of us can go up and see that person and just make a quick mental note that actually there is a carer's issue, there is a social work issue, there is an OT issue. And then we can contact our colleagues and they can follow up. We have a community, an inpatient and a community role, so we're allowed to chase people out of the hospital as well. Also, we set up an information sheet for the day admissions because they were coming in and we had no idea what stage they were at. So it was useful just to have a tick box list. Do you have carers? Do you have equipment? And then we knew where to start the assessment from. So really, the benefits are that it encourages reflective practice. You can explore a wide range of different issues, as I say, both emotional and organisational and mundane. We're continuing with our joint assessments. We value we feel valued as a team within our little team. We feel valued as a team anyway, but within our little team we do. And we feel that it has enhanced the longevity in the workplace. And also that it's improving that sort of streamlining of practices when they're delivered, hopefully seamlessly to the people with motor neurone disease. So our next step is we're going to increase our regularity so that we have slipped slightly because of timings and things, but we can start up again. And also it's to fly the flag and encourage other people to do it as well. So that's your challenge. Thank you.
Thank you, Melanie. Questions? Next question after this one. Put your hands up.
Thanks, Melanie. It's Eric Kelly from MND Victoria. Hello. I just wondered about how you go about setting the agenda and prioritising it. And also a second quick question was the venue for these sessions. Are they on-site or do you go off-site somewhere?
We have been known to wander down the street from the Austin and go and have a little conflab in a local coffee shop. But usually they're held in the we've got a very nice round table, which is good in the OT department, which is usually the sewing table, so I have to move the machine and stuff. So that's where they usually happen. We usually have them just before our management meeting as well, which is extremely useful because any hot topics that have come up during our peer supervision meetings, we can then take straight to management meeting and then make them do something about it. And yes, the ideal is sort of 4 to 6 people in each group. So you could have lots and lots going on in one setting. So if the nurses or the physios decided they would like to follow this model, and we keep telling them they should, but they don't listen. That you can have separate meetings, because in a way it's just what comes out of the meeting is the important bit, and the fact that there is a forum to talk about these things is the important thing, rather than that they all know what the other ones are talking about, because that's not an issue. Okay.
Questions? In the middle, towards the back.
Hi, thank you for your presentation. I'm Karen and I'm an OT. I was just wondering how, or if it had progressed to the rest of your other teams, the OT and social work teams, or not.
They do. They have a certain amount of structure. There's quite a lot of supervision at the Austin, and we're not very influential to anybody. We just go and do what we do. I think there's lots of interest around peer supervision, and I think they can get a bit big and cumbersome sometimes as well, which is where this model wins out, because it says 4 to 6 people. Any more than that, make another one. And there is evidence that it's coming to the fore, either in groups that are quite isolated and small in a way like ours, or in groups that are quite widely dispersed. And the electronic media has meant that you can kind of do joint supervision, peer supervision sessions. And some of the social workers in the rural areas are using it as a way to support each other. So it can be used in a number of settings, which is useful. But we're still spreading the word.
One last question over here on my, whatever this hand is.
Hi there, I'm Justin Ware, OT, working with technology. I just had a question. You mentioned about the social workers, working in rural areas. Do they meet up in person, or do they do a lot of telephone?
They're Skyping each other. So they do it over Skype, and which is fabulous use of the technology. and yeah, perfect.
Okay, well, join with me in thanking Melanie. Our last speaker before morning tea, and I can all see us with that desiring of drugs on our faces, is Patsy Pine, and Patsy's going to be talking about improving continuity of care, a social work perspective. Patsy.
Thank you, Rod. Welcome everyone to our beautiful city of Sydney. I work at Calvary Hospital, which is in Kogarah, Sydney. And Calvary has 2 main streams. One is an aged care stream with community team and inpatient rehab, and the palliative care team, inpatient and community, and I work in the palliative care section. And today I'm going to talk about a change that we made to our M&D model of care a couple of years ago, and talk about why we made that change and what the effects have been. Can you all hear me? Yeah. I'm also going to talk about changes we still need to make to our model of care at the end of the paper. When the MND service was established 10 years ago, there were only actually 3 members of the team. There was a rehab specialist, a palliative care specialist, and a clinical nurse consultant. And any referrals that were made for allied health were made to one of 3 different teams in our geographic area we cover. So it might have been allied health attached to the aged care team, one of 2 aged care teams, or to the palliative care team, meaning there was actually no continuity of care or consistency of care from allied health, including social work. Basically, the referrals were made were based on where the person lives, her residential address, or based on caseload, or based on whether the person was entering, the MND client was entering the terminal phase of the disease, and then they were referred to the palliative care team. So in 2004, I was working actually on the aged care team at Calvary, and I got my first referral of a client with motor neuron disease. Her name is Joan, and Joan has given me permission to tell her story. In fact, she wanted me to tell her story. Joan was 68 and had just been diagnosed with MND, was a clinical nurse consultant in our area, was recently widowed, and had limited family support. At that time, I knew very little about motor neuron disease, but she took me on a very steep learning curve or course or whatever. Joan was articulate, she was very funny, but by the time I even met her, she was already losing voice, and her means of communication was writing. She spoke openly about the issues she was confronting: loss of professional and personal independence, concerns about finances, fears about her future care, and especially about her loss of voice. She spoke of the impact of having numerous and changing allied health professionals through the course of her illness, and how overwhelming it was when she had to reconnect each time a change occurred. She was particularly critical of constant social work changes, especially as she had no voice, and therefore communication was extremely difficult for her and time-consuming for all involved in her care. As Joan's illness progressed, so too did she progress through the various allied health, inpatient, and community teams in our area. She saw 4 different social workers in the 18-month period of her disease. When she entered the terminal phase of her disease, she was referred to the social worker attached to the palliative care community team, and at that point she said, "Enough's enough, I will not see another social worker." She said, "Instead, Patsy, what I want you to do is advocate at Calvary using my written voice, asking that they consider having one designated social worker who's attached to the client from time of referral to death." So, being a compliant person, I did as I was told. And I guess the impact that Joan had on me made me become a very strong advocate, because I absolutely agreed with her. So in 2005, Calvary did agree to have one social worker attached to the MND clients, and these are clients that we see both in clinic and follow up in the community, and I've been in that position ever since. Joan actually waited and waited to see how I would do with my advocacy, and when I finally came to say to her that we had won, she then passed away 3 days later. Okay, so what do I see as the advantages of having a designated social worker attached to the service? It provides continuity of psychosocial care for clients and families. It strengthens the social work role as advocate for MND clients and their family cares, increases opportunities to provide support within the team when working in this challenging and often confronting area, increases awareness of gaps in service provision to these unique clients, and has identified a need for training staff in the specific care needs of MND clients. So since I've been in that role, one of the gaps, or one of the things I noticed, was many of our MND clients and family carers were less likely to access support services in the home or respite compared to my palliative care client group. I meant to say I worked 2 days a week with palliative care and 1 day with motor neuron disease, and I saw these differences. The other thing I noticed, well, part of the reason was families said and clients said, "Oh, we're not comfortable with people coming in, either because they don't understand our care needs, they can't understand our challenges with communication, we're embarrassed by some of the physical symptoms, the saliva, blah, blah, blah." So we decided we would train paid carers, and we did that, and then encourage families, having told them we'd done the training, to actually begin using these services. We also did a lot of in-service training for the inpatient caring staff so that people would use respite. Now, what have these clients taught me? I'm just going to do this wonderful quote from Santarelli. "Those seeking our care, those we call patients, are our teachers. The healing relationship has always been a crucible for mutual transformation. We need to have a willingness to hear one another, to sit together without judgment, without giving advice, without reaching for easy answers or invoking shallow affirmations. What I've learned is I've got an increased awareness of the impact of this disease, increased awareness of the need for continuous intense support. The needs of MND clients and their family carers differ to cancer patients, and increased confidence working with people who are in shock, overwhelmed, depressed, or facing a sense of hopelessness, and taught new skills in communicating and in hearing people who don't have voice. It's also instilled in me a very positive attitude and a sense of hope, which always surprises people that I work with. What do I mean by a positive attitude and a sense of hope? I'll just give you two quotes here. One is from Vitaly and Genge, who work in the Neurological Hospital in Montreal. Hope is about far more than survival. It is also about meaning, comfort, dignity, relationships, purpose, and many other aspects of daily living. And once the goal of survival is lost and a foreseeable death is in sight, that goal needs to be mourned, and many people can then redirect their energies into developing new goals that are important, realistic, and relevant to them. Sometimes in this process, positive goals and emotions are generated, and that has certainly been my experience in the past 6 years. The two major areas, or there are many areas, but the two major ones confronting people with motor neuron disease and their family carers are obviously the very rapid physical decline and the loss of effective communication. And these two areas were emphasized. I did a survey a couple of years ago with MND clients and family carers, asking a lot of questions, but one of them was talking about what is the most challenging aspect that you feel you're facing. And certainly the main one was the communication issues. And I recently did a survey with my allied health colleagues at Calvary, both in the aged care team and the palliative care team. And again, they emphasized obviously the rapid physical decline, but the real challenge is when people are no longer effectively communicating. And even though we saw this morning in that video that Sally, you showed, I have not yet had any client that's had access to such highly specialized communication technology. And so I'm hoping through the conference the next few days I'll learn about that sort of technology. Just a quick thing about loss of voice. I guess one of the things I learned early in working with Joan was just the incredible power of the loss of voice, particularly when as a social worker you're working with people where usually the tool that we use is communication and talking and exploring their feelings or emotions, and discover with Joan just how difficult it is to do that exploration when the person has no voice. She chose not to use a light writer. She wanted to write, but it certainly slowed things down. And there's, I guess, one of the things about voice is it's not just about communication, it's the way the words we use, the way we say them. It says a whole lot about us and about the person we're talking with. So it's a very rich tool we have that is lost. And this is a quote from Joan. I guess I had no idea how difficult life was going to be to have to write everything down. This is once she'd gone into care, by the way, or to use a light writer. They seem to think handling a light writer will solve everything, but they don't realize how many times you have to repeat yourself as staff changes and new staff want to know about your care. And the second quote comes from an occupational therapist in the States who actually worked with people with motor neuron disease, and then her mother developed the disease and she cared for her at home. And the loss of my mother's ability to communicate was by far the most heartbreaking loss of the ALS experience. It's difficult enough to grieve, to express fears and pain, and to share one's heartfelt sentiments when one can communicate easily. How much more traumatic it is when communication is impaired. Now, I just want to quickly tell you about the model of care, the good things that we do at Calvary, and then where there's some challenges we have to face. What I believe we do well is, first thing is the multidisciplinary team. Yes, we sort of have one, but I guess Richmond and Casey point out the interpretation and use of this approach varies among individual healthcare professionals and teams. And I'll talk a bit of the Calvary one. In our model of care, the good thing is we recognise from the time of diagnosis that this is a terminal illness. We provide holistic multidisciplinary care to clients and their carers. We have a designated social worker now attached to the team. We offer an outreach home-based service to MND clients and family carers, and we can access inpatient beds at Calvary Hospital for clients when family carers need respite or the client needs medical review. We provide in-service education to our professional carers, meaning the inpatient staff, including our volunteers, pastoral care workers, nurses obviously, and allied health. We provide in-service to in-home paid carers, so if a client's bringing in a service to care for them, we'll go out and do some education. And residential care staff when someone moves into residential care, and we continue a social work in the CNS and our PAL care specialist follow these people even into residential care. We provide end-of-life care at Calvary, and we refer family members to our bereavement service, which is free and is an excellent service. Now, where are the gaps we're facing? This is a quote from Hughes, during the course of the disease, people will come into contact with a wide range of health, social and palliative care services. They'll need input from several professional groups. This can be overwhelming and confusing. This input needs to be prompt and well coordinated. Because of the relatively low incidence of the disease, most health professionals have limited knowledge and expertise in this area and lack confidence. So the problem at Calvary right now is when I'm in my caseload, I could be dealing with, if I have, let's say, 25 MND clients, I could be working with 4 or 5 OTs, 4 or 5 physios, depending on where the person lives or what stage of the disease they're at, which is not an ideal way to run an MND service. And I always aim for the ideals. Joan taught me to do that. So at the moment we have no designated OT, physio or dietitian. We have a designated speech pathologist, but that's only because we only have one that covers all the areas, so we have her designated. Clients are followed up based on residential address or stage of disease, resulting in changes to allied health carers. So the person may be seeing 2 or 3 OTs, just as Joan saw 2 or 3 or 4 social workers. The multidisciplinary team is fragmented, and there are decreased opportunities for professional growth and decreased opportunities for contribution to case conferences where knowledge is shared and goals are set. In conclusion then, what I'm aiming for and hope to achieve before I retire is that we'll have a designated OT, physio, speech pathologist and dietitian attached to our team. And I also, I guess because I've felt such rewards in doing this work consistently over 5 years, I have no doubt that the allied health colleagues that I work with who do actually like this work would also benefit from that continuity of care. And I just end up with a quote about hope. Hope is a driving force that enables patients and families to persevere. It is one of the most important factors in maintaining quality of life. Our attitudes, beliefs and opinions are conveyed to patients and families. Thank you.
Thank you, Patsy. Any questions? One down the front. Any other questions?
Janine Arnold, Motor Neuron Disease Association of Tasmania. What do you see as the main block? What's the difficulty about getting dedicated OTs and physios in that team? Is it part of the structure, or is it resources, or?
Yeah, that's a very good question. I can get access to the OTs and physios that I need. It's just because it's all fragmented. The problem is funding. There's the OTs I get from the aged care team are funded through one branch of Calvary. The palliative care is another. And so when I go to them and say I want one, instead of having all these hours spread out over 4 OTs and 4 physios, let's just have one person, then there's an argument about who's going to pay for those hours and who's going to pick up the rest. So that's the block I'm facing at the moment. And I guess that the other issue, I guess, would be if one OT is assigned, not her whole caseload, but if she takes on the 25 clients, for example, then the others are picking up the rest of the caseload. So it's all to do with structure. I see it as a very simple problem, but that's because I can't manage a budget, not even my own. But I'm hoping to convince them that in the end it's actually economically more viable to do it the way I'm suggesting, I think.
Jane Dew, I'm a palliative care nurse from Hobart. I'm interested in your comment that MND and
Sorry,
cancer...
could you speak a little bit more
Interested
strong?
in your comment that MND and cancer are very different. It's a problem we've wrestled with in our team for quite a long time. Obviously, we deal with many more people with cancer than with MND. Have you got any comments on it?
Yes, I do. I could write a whole paper on that. How much time do I have, Rod? Just joking.
Never joke about time.
He scares me. I've given this a lot of thought. I think there are very significant differences, and it's why I think they need to have designated allied health to this group. The first difference is it's a diagnosis immediately without any, interventions, no chemo, nothing that is going to at least help someone sustain hope for a while. It's rapidly progressive and physically very, very debilitating. If you think about carers, and I think about my carers of cancer patients, I'm not saying that's an easy job nor an easy diagnosis, but carers of MND are often dealing with BiPAPs, PEG feeds, positioning, hoisting, toileting, and it's more physically demanding in most cases. And there was another point I was going to make. For example, I have no problem handing over I work in palliative care, inpatient team, rotate to the community, rotate back. Have no problem handing over any client or family I've worked with to my colleagues, my social work colleagues. It's a seamless transfer. You introduce them, they pick it up, they run well with it. I have great trouble handing over my MND clients like Joan and like all the other hundreds of clients I've seen as they're losing voice. So I think there's a big difference in why this client group needs needs continuity of care. Not to say you're not going to eventually move on in your jobs and move on to another area or retire, and then someone else picks up the skills. But while that person is going through so many losses with little hope, the one hope they have is that you will stay with them, and they beg you, and Joan begged me not to abandon her. So I think does that answer your question? If anyone disagrees with me, I'll see you over coffee.
Question in the middle.
Oh, hello. Mary Slater from Ballarat, Victoria. Just to that end, I really agree with you about the continuity of personnel, but do you identify compassion burnout in that, and how do you deal to prevent that from occurring?
That's a very good question. I was hoping nobody would ask me that question. I haven't felt that impact until very recently, to be perfectly frank. I have been very positive, and that stuff I said and wrote is how I've been feeling. Just lately I've been feeling the strain, and partly that's based on increasing caseload. How I deal with that is that I think how I deal with it better is if I had if we all had a very tight team to support each other rather than have to have all these fractured teams. I guess the thing that keeps me going is the sharing with the palliative care specialist, Frank Brennan, who will be speaking, I think, tomorrow on one of the talks talking about MND and palliative care. Is a very supportive colleague, and the clinical nurse consultant is an incredibly hard-working and compassionate person, so we support each other that way. I think what I lost in the last few years of being so perhaps committed to this area, someone told me I was on a crusade. So I began thinking I'm going to have to begin taking better care of myself and recognizing that, and that's where that peer supervision that was spoken about and reflective practice really helps. You've got to watch yourself because you do. Someone told me working with motor neuron disease was seductive. Now, what kind of word is that? I thought, that's ridiculous. Well, it seduced me.
Any last questions? Can I just say there is a fantastic presentation as part of the symposium in the next couple of days on compassion fatigue. I think that will certainly be worth attending.
Thank you.
Thanks, Patsy. Look, I'd like you to join with me in thanking all of our speakers from this morning. I think we've kicked off today really well with an interesting and challenging series of presentations. Now, before you move, because morning tea has been made available outside, can I suggest that those that are in the rear corner of the room impeded by this column, you might like to move in and down when you come back. There are some vacant seats at the front. Can we have all of the speakers for the next session down the front to meet with Steve? And can you all be back on time? We will definitely be starting at 10:50 with your mobile phones, pages and anything else that beeps or bleeps off, and we will kick off again at 10:50. So enjoy morning tea and thank you.